How's it going, guys? So this is my third microbiology presentation here on YouTube. I made two others on the gram-positives. Like those presentations, this one is going to cut to the chase and just focus on the high-yield points you need to know to increase your score on the USMLE. This is not going to be a long, meandering School of Medicine type of presentation, focusing on information that would never be assessed in a million years, okay? So before we get started, I will be my typical asshole, tell you to subscribe to my channel. I really appreciate it. Hit the like button. Hit the bell if you want notifications. Find me on Instagram at Melman_medical, MEHLMAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now, let's start the fucking presentation here where we have two important visual algorithms. We are not going to spend 16 minutes on this one slide. By all means, you can pause the presentation here. If you commit these to memory, your retention will be improved going forward. So we're going to start with the gram-negative diplococci, Neisseria, meningitidis, and gonorrhoeae. Do not confuse this with strep pneumo, gram-positive diplococci. So Neisseria meningitidis has a polysaccharide capsule. Gonorrhoeae does not. Gonorrhoeae has a pilus protein that can undergo antigenic variation. Neisseria meningitidis does not. How is this relevant? We can make a vaccine. We have a vaccine against Neisseria meningitidis. We do not have a vaccine against gonorrhea. For the USMLE, in cases of asplenia, splenectomy, and sickle cell, we vaccinate against the encapsulated organisms. So Neisseria meningitidis, strep pneumo, Haemophilus influenza type B. Neisseria meningitidis gonorrhoeae can be grown on Thayer Martin medium. It contains nystatin, polymyxin, and vancomycin. And it's a chocolate agar. USMLE is obsessed with terminal complement deficiency, okay? So it's not my opinion as to what is high yield. It's what shows up repeatedly on the NBME content, offline and online. So you'll get a question where they might say, there's Neisseria meningitidis meningitis, and they'll say, this patient has immunodeficiency. What's the most likely cause? And the answer is terminal complement deficiency, all right? We need to be able to form the MAC attack, the MAC complex in order to kill Neisseria. Or they might say recurrent gonococcal infections, and the answer is simply terminal complement deficiency. So Neisseria meningitis classically causes meningitis in close quarters like dormitories, military barracks, and also causes a non-blanching rash. Very important, okay? So if you get a case of meningitis on the USMLE, and you say, well, how am I supposed to know what it is? Is it strep pneumo, Neisseria, which one is it? If they say that there's a non-blanching rash, that's Neisseria meningitidis. Neisseria meningitidis causes Waterhouse-Friderichsen syndrome, very high yield. So meningococcal septicemia can cause a bilateral hemorrhagic necrosis of the adrenal glands. If we lose our cortisol, then cortisol's role is to normally upregulate alpha-1 receptors on vascular endothelium in arterioles. That allows norepinephrine, epinephrine to bind to those alpha-1 receptors, maintaining vascular tone. If we lose our cortisol due to the hemorrhagic necrosis of the adrenal glands, then we can't maintain vascular tone, low blood pressure, okay? So the USMLE loves you to know that after you give normal saline, you're going to give hydrocortisone. You need to replenish your glucocorticoids in the setting of Waterhouse-Friderichsen syndrome. And don't confuse the hemorrhagic necrosis of the adrenal glands with the ischemic necrosis of the pituitary that we see in Sheehan syndrome postpartum. As I mentioned, vaccination for Neisseria meningitidis, asplenia, sickle cell. Now, Neisseria gonorrhoeae, when we talk about the STI, mucopurulent discharge, they will tell you gram-negative diplococci are visualized on a gram stain. If they want chlamydia, they'll tell you no organisms are seen because chlamydia is intracellular. So gonococcal arthritis is very high yield. It's going to present mainly as two ways. The first is a triad of arthritis, can be mono or polyarthritis, cutaneous papules, and tenosynovitis, which is inflammation of tendon sheaths. USMLE will classically give de Quervain tenosynovitis, which is pain on the radial side of the wrist, classically seen in breastfeeding women, but they like giving you cutaneous papules, usually along the wrist, and pain on the radial aspect of the wrist, plus arthritis. That's gonococcus on USMLE. That's one presentation. The other half of questions are going to give you simply 22-year-old male who's sexually active, not using condoms, and he's got a monoarthritis of a large joint such as the knee. That's it. The answer is gonococcus. And then I throw in here as a sort of a tertiary point that there is one question I've seen where they said sternoclavicular joint was involved and gram-negative diplococci were cultured. So this can get a little bit annoying. Gonococcal arthritis is notoriously difficult to culture. So when we talked about the mucopurulent discharge due to the STI, okay, penile or vaginal discharge, they will say gram-negative diplococci are visualized if they want gonorrhea. And as I mentioned, they will say no organisms if they want chlamydia. However, when we talk about arthritis, they will tell you joint aspiration arthrocentesis is performed, no organisms are grown, but they're forcing you to choose a bacterium. And the answer is going to be gonococcus. Okay, that's important for USMLE. Disseminated gonococcemia is difficult to culture. Okay, so gonococcal arthritis, as I mentioned just above, is different from reactive arthritis, which is chlamydia. Okay, formerly known as Rider syndrome. HLA-B27 patients classically will get urethritis due to chlamydia, plus red eyes, eye-itis colloquially, conjunctivitis, episcleritis, and obviously your arthritis itself, generally a polyarthritis. That's chlamydia. That's reactive arthritis. But gonococcal arthritis is different from reactive arthritis. So pelvic inflammatory disease in females, inflammation of the adnexa fallopian tubes. So this can cause scarring, leading to ectopic pregnancy, okay? And we are going to treat with IM ceftriaxone for the gonococcus, plus either azithromycin or doxycycline for the chlamydia. And for pelvic inflammatory disease, I should also mention that cervical motion tenderness or lower left quadrant or lower right quadrant pain, high yield, okay? But cervical motion tenderness, very buzzy for PID. So neonatal conjunctivitis, aka ophthalmia neonatorum, gonococcus can cause it. So topical erythromycin ointment can be used to prevent gonococcal ophthalmia neonatorum. Fitzhugh-Curtis syndrome is inflammation of the liver capsule due to severe pelvic inflammatory disease. Just know it exists and know that you can get fibrin exudates on the liver due to PID. Sounds weirdly specific. I've seen it on path questions for step 1. Serratia marcescens, the only thing you need to know is that it's catalase positive, and it can show up as Serratia sepsis in patients with chronic granulomatous disease and ADPH oxidase deficiency where they have susceptibility to catalase positive organisms. Details such as how Serratia is red in color, cherry red, or that it can cause UTIs, not super high yield. As I said, you just need to know that it can show up in CGD, chronic granulomatous disease questions. E. coli, okay, so enterotoxigenic E. coli classically causes traveler diarrhea. There's heat labile and heat stable toxin. Heat labile toxin is going to ADP ribosylate adenylyl cyclase, increasing CAMP. In contrast, heat stable toxin, ADP ribosylation of guanylyl cyclase, leading to increased CGMP, okay? Now, the heat labile toxin is similar to cholera toxin. The heat stable toxin has the same mechanism of action as Yersinia enterocolytica toxin. So, heat labile, cholera, both increase CAMP. Heat stable, Yersinia enterocolytica, both increase CGMP. Yersinia enterocolytica causes bloody diarrhea, whereas ETEC, both heat labile and heat stabile, and cholera all cause watery diarrhea. The way you differentiate traveler diarrhea from cholera is cholera will present as liters and liters, okay? Very high volume, profusely high volume rice water stools, whereas traveler's diarrhea, they will not describe as exceedingly high volume, okay? A lot we can talk about. Enterohemorrhagic E. coli, O157H7. This produces Shiga-like toxin. It's the Shiga-like toxin that is most responsible for the virulence of EHEC. And likewise for Shigella, the Shiga toxin, both of these toxins are going to cleave the 60S ribosomal subunit. Shigella, its ability to invade that actually is going to be most responsible for its virulence over the toxin, whereas EHEC does not invade, and it's just the toxin itself that's most responsible for the virulence. So these toxins will disrupt translation because they're cleaving the 60S ribosomal subunit. And hemolytic uremic syndrome, this is going to be the toxin goes to the afferent arterioles of the kidney, causes endothelial damage, the platelets will mop up the platelets will go to patch up that endothelial damage. Thrombocytopenia, because they're being consumed, and the platelets will stick out into the lumina of the vessels, shearing the RBCs that fly by, causing a schistocytosis. So the combination of thrombocytopenia plus hemolytic anemia with schistocytosis is called MAHA, microangiopathic hemolytic anemia. Okay, it's very annoying, it's very confusing, but you should just know thrombocytopenia, schistocytosis equals MAHA. That's classically seen in HUS, also seen in TTP, HELP syndrome, DIC. Okay, and HUS is going to be the triad of the thrombocytopenia, the schistocytosis, and the renal insufficiency. TTP is going to be a pentad where you add fever and neurological signs on top of it. There's a lot we can talk about. I don't want to go off 15 minutes right now on that discussion point alone. So E. coli, most common cause of UTIs if the USMLE asks you, and you should know it's an important cause of prostatitis epididymitis in males who are generally 45 or older. There's no one age that has to be a cutoff. It's more that the USMLE, I've seen a question where they just say prostatitis in a 45-year-old male, no other information. Chlamydia is the wrong answer. E. coli is correct. All right. Younger males, you want to think chlamydia over E. coli. And by the way, P. pillis and Vibrio are two components of E. coli that allow it to adhere to transitional cells of the urothelial tract, if USMLE asks you. Neonatal infections caused by a gram-negative rod is E. coli. So neonatal infections, as I talked about in my gram-positive presentations, if they say gram-positive cocci, you know that that's going to be group B strep. If they say gram-positive rods, Listeria, gram-negative rods, E. coli. And for whatever fucking reason, we can see E. coli sepsis in classic galactosemia. We can posit and speculate as to why, maybe due to the lactose fermentation, etc., but it's just a detail you can throw on the back burner. And E. coli, similar to Serratia, can be seen in chronic granulomatous disease because it's catalase positive. Klebsiella causes aspiration pneumonia. So we can see this in alcoholics, for instance, who have increased risk of aspiration. Currant jelly sputum, it's a thick red sputum that it causes. And Klebsiella can create cavitations in the lungs. If they say, let's say an alcoholic who has a cavitating pneumonia, Klebsiella is the answer. Thick mucoid colonies, just a buzzy descriptor you should be aware of. And it's urease positive, so if they mention UTIs with Klebsiella in the setting of renal calculi, it's staghorn, ammonium magnesium phosphate, which these stones occur at increased pH of the urine. Proteus will also cause staghorn calculi. It's urease positive. That's pretty much the only thing you need to know for USMLE, for Proteus. Salmonella versus Shigella. Shigella requires few organisms to cause infection. Salmonella requires many organisms to cause infection. So, and once again, Shigella is from the algorithms before, Shigella is non-motile and does not produce H2S gas. Salmonella is motile, swarming motility, and it produces H2S gas. Those details are slightly lower yield. That's why I'm not mentioning everything in the slides here. So Salmonella, the food poisoning, is typhimurium plus enteritis, and you get this from chicken, poultry, okay? Eggs, turtles. Do not confuse this with Salmonella typhi, which causes typhoid fever. Humans are the reservoir, okay? Not chickens, not turtles. Typhoid fever is going to be high fever, generally 40 degrees Celsius or greater. Rose spots on the abdomen, and the patient is prostrated, which means lying down, very ill, and it can present with either constipation or diarrhea. Shigella, so shigellosis versus HUS, I've seen this distinguished on NBME. Shigellosis will just be bloody diarrhea. So Salmonella and Shigella both cause bloody diarrhea, all right? But if they say bloody diarrhea, that's going to be shigellosis alone. HUS, in contrast, as we talked about briefly before, is thrombocytopenia plus schistocytes, okay, and with low hemoglobin due to hemolytic anemia, plus renal insufficiency or blood in the urine. So if you don't see that full triad for HUS, the answer is shigellosis, not HUS. Okay, so Pseudomonas, classic cause of pneumonia and cystic fibrosis patients. You should be aware that under the age of 10, Staph aureus eclipses Pseudomonas as the most common cause. They equal each other in prevalence at age, or I should say incidence at age 10. And then after age 10, Pseudomonas eclipses Staph aureus. Nosocomial infections, okay, very important detail for Pseudomonas. So hospital and ventilator-acquired pneumonias, 2CK likes broad-spectrum antibiotic therapy to treat Pseudomonas and MRSA. So upper generation cephalosporins, third generation ceftazidime, fourth generation cefepime, those will treat Pseudomonas plus vancomycin for MRSA. That's called broad-spectrum antibiotic therapy, okay? So an upper generation cephalosporin plus vanc. And likewise, aminoglycosides, tobramycin, amikacin, are very effective against Pseudomonas. Pseudomonas causes hot tub folliculitis, okay, inflammation/infection around hair follicles. It's an important cause of otitis externa of your outer ear. In contrast, otitis media is strep pneumo most frequently. And if you get a patient who has burns with a blue-green color, that's due to pyocyanin of Pseudomonas. Don't confuse with, if you get a burn where it's yellow in color, that's golden staph, okay, Staph aureus, not Pseudomonas. Pseudomonas infections increase risk in diabetes, osteomyelitis. I should point out there's a new 2CK question where they say a diabetic foot ulcer and a sterile probe is placed at the base of the lesion. And Pseudomonas and Staph aureus are both wrong answers. The correct answer is polymicrobial. This is a very valuable NBME question because it settles the... I took the USMLEs a decade ago, and it had been debated for years about is it Pseudomonas or Staph aureus is most common cause of diabetic foot ulcer. NBME question, as I said, they're both wrong. Answer is polymicrobial, okay? Ecthyma gangrenosum is going to be painless black skin lesions and disseminated Pseudomonas infection, increased risk in diabetes. So Vibrio cholera, profuse watery stools, as I mentioned before, do oral rehydration therapy if at all possible. And the toxin increases CAMP, as I mentioned prior, same as heat label toxin of ETEC. So Vibrio perihemolyticus, I've seen it on the NBME exams, the offline NBME, as consumption of sushi. You'll read that Vibrio perihemolyticus and vulnificus you get from shellfish. But when we talk about, rather than hypotheticals, what are we actually seeing on the NBME exams? As I just fucking said, I've seen perihemolyticus associated with consumption of sushi. Vibrio vulnificus shows up on NBME 18 or 19 offline as a dude running on the beach who gets sepsis. Okay, it's a weird fucking question, but that's what it is. And if you have to choose one or the other, vulnificus or perihemolyticus, if they happen to list both and they say that the patient has sepsis with low blood pressure, choose Vibrio vulnificus. Okay, it's more severe than perihemolyticus usually. So Yersinia enteroclitica causes bloody diarrhea and also pseudoappendicitis plus arthritis. So pseudoappendicitis, right lower quadrant pain due to terminal ileitis / mesenteric adenitis. It's also a cause of reactive arthritis. So reactive arthritis need not be urethritis due to chlamydia. It can also be due to GI infections, okay? I've seen, I don't want to get too tangential, but I've seen one 2CK question where they said antibiotics were given, and then they said there was left lower quadrant pain, bloody stool with cramping, okay? And the answer was C. diff, not Yersinia, okay? So Yersinia will be right lower quadrant pain. And C. diff can be bloody stool, as I talked about in the gram-positive presentation. Yersinia pestis causes bubonic plague. Buboes are painful lymph nodes spread by fleas. And pneumonic plague, you should be aware that Yersinia pestis can cause a quote-unquote weird pneumonia in a farmer caused by a gram-negative rod. Helicobacter pylori, classic, spiral-shaped. It's urease oxidase catalase positive. Urease being the most important, of course, allows it to survive in the acidic environment of the stomach. Important cause of peptic ulcers. So peptic ulcer is an umbrella term for duodenal ulcers and gastric ulcers. Duodenal ulcers, almost always, greater than 95% of the time, are due to H. pylori. They can also be due to Zollinger-Ellison syndrome, gastronoma. Gastric ulcers are frequently caused by H. pylori, but there's many other causes of gastric, such as NSAIDs, can be burns, curling ulcers, can be head trauma, Cushing ulcers. So H. pylori also causes type B gastritis. So type B gastritis is inflammation / infection of the antrum of the stomach. That's H. pylori, okay? Whereas type A gastritis is of the fundus and body. That's autoimmune. That's due to autoantibodies, type 2 hypersensitivity against parietal cells, causing pernicious anemia, megaloblastic anemia, B12 deficiency, hypersegmented neutrophils. And H. pylori, the mechanism is that it secretes proteases that damage the mucosal barrier. It can cause malt lymphoma, mucosal-associated lymphoid tissue. It's a B-cell lymphoma of the stomach. And you can diagnose with urea breath test or stool antigen. EGD is esophagogastroduodenoscopy. It's just an abbreviation for endoscopy. And biopsy showing the spiral-shaped organisms is confirmatory after we do a urea breath test or stool antigen. That's more 2CK, knowing the management there. And of course, CAP, this is 2CK as well, but you should at least be aware of the of this treatment regimen for step 1. So clarithromycin amoxicillin proton pump inhibitor, CAP. If patient takes CAP for 7 to 10 days, and then 4 weeks later still has a positive urea breath test, we assume resistance to the clarithromycin amoxicillin. We substitute those antibiotics out, and we instead do metronidazole, tetracycline bismuth, plus a PPI, okay? Quad therapy. Now, if you're a fucking gastroenterologist, there's many different regimens, okay? But we're talking USMLE here. Things are simplified. So no CAP, okay? Campylobacter jejuni, this is one of the few organisms that USMLE can sometimes get a little bit pedantic and detail-oriented in the vignette as far as its growth characteristics. So oxidase positive, urease negative, it's a curved rod, or comma-shaped rod, and it can grow at high temperatures, 42 degrees Celsius. And it's one of the most common causes of bacterial gastroenteritis, and it'll cause bloody diarrhea. And poultry is the source. This was on an offline NBME. They literally just gave you Campylobacter jejuni, and then you could narrow it down to chicken or beef. Answer, chicken. And of course, it causes Guillain-Barré syndrome, which is going to be an inflammation of the endoneurium, causing demyelination, ascending paralysis. And this can present many different ways on USMLE. They do not have to mention a barbecue beforehand. Don't get pulled into the trap of they have to say that there was an infection beforehand, okay? More difficult questions will just, if they give you ascending paralysis, be able to infer that that could be Guillain-Barré. People might not remember that they ate something in particular. Albuminocytologic dissociation of the CSF, that's going to be high protein with normal/few cells in the CSF. And we treat with plasmapheresis/IVIG. Steroids for Guillain-Barré? Wrong fucking answer, all right? So Bacteroides, very important anaerobe for USMLE. If there's one thing you need to remember, anaerobes, and it can cause pulmonary abscess/aspiration pneumonia. Now, I mentioned before, Klebsiella is also an important cause of aspiration pneumonia in alcoholics. So alcoholics, classically aspiration, can be Parkinson's disease, can be Alzheimer's disease, they lose the gag reflex, can be epilepsy where they aspirate. Foul-smelling sputum is the USMLE's way of telling you anaerobes. So let's say you're forced into a position where they have Klebsiella or Bacteroides as answers for pneumonia in an alcoholic, and they say foul-smelling sputum. You should be thinking anaerobes, Bacteroides. Okay, so this is a very high-yield question. You might get an alcoholic who has a fever plus an air fluid level seen on chest x-ray. Air fluid level means pulmonary abscess. It means you have a circle, and then due to gravity, the pus within the abscess will settle. So you have a white semicircle on the bottom, that's your pus, and then you have a black semicircle on the top, that's your air. That's called an air fluid level. That's abscess, okay? And they want you to know, they'll say, what's the cause? Answer, oropharyngeal normal flora, okay? They're talking about Bacteroides. So, as I mentioned at the beginning of the presentation, this is the algorithm for both the gram-negative rods and the gram-negative diplococci, that if you commit these to memory, your retention will be greatly strengthened, okay? It's to my observation with students that if they have trouble remembering the organisms, it's because they don't have a visual association. Once again, we're not going to make this a 49-minute presentation. We're just focusing on the high-yield points here that are supposed to increase your score, okay? And you know the deal. I'm going to continue making more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.